brought groceries. Grandma? Grandma?
What you have just seen is an example of a scenario that occurs all too often among senior citizens. Individuals are admitted to the hospital, treated, and eventually discharged. The period of time after their hospitalization is one of increased risk for readmission. In our example, Mrs. Kane was unable to fill her prescription and therefore had to be readmitted to the hospital when her granddaughter discovered her. There are many causes for people to be sent back to the hospital. Sussex County is pioneering a program to decrease these readmissions called the Transitional Care Program. Let's hear from the program's team about how TCP works.
I'm Sarah Balzano, the Transitional Care Nurse and the Coordinator for the Sussex County Transitional Care Program. The Transitional Care Program was started in an effort to identify the needs of the seniors in our community and making sure that we can try to help them obtain all the services necessary to cut down on readmissions and allow them to stay home and independent in the community as long as possible.
Hi, my name is Steve Brujas, and I'm the Sussex County Human Services Administrator.
I'm Dr. Wong. I'm the Medical Director of the Sussex County Transitional Care Program.
Hi, my name is Donna Green. I'm a social worker for the Transitional Care Program.
My name is Regina Hanapple, and I'm a social worker for the Sussex County Department of Human Services Transitional Care Program.
My name is Elizabeth Larson, and I'm a social worker with the Division of Senior Services for the Transitional Care Program.
I'm Ardell Bugos, Chief Nursing Officer at Newton Medical Center.
My name is Christina Marks, and I'm the Wellness Coordinator for the Division of Senior Services.
My name is John Eskelson. I'm the County Administrator for the County of Sussex.
I am Gail Phoebus, freeholder of Sussex County, and I am the liaison to the Human Services of Sussex County, and that part of the Human Services is the Transitional Care Program.
One participant of the Chronic Disease Self-Management Program said, "Your program encouraged us to think about problems, find solutions, and implement them to the best of our ability."
One of the things that we realize is that healthcare in the country has changed over the past many years, actually. And right now there's a big emphasis on readmissions to hospitals. So we knew that some of the local hospitals were having problems with their readmissions of their patients, so we started to take a look at that to determine really what was the reason for the readmissions, particularly with our senior citizens.
In April of 2012, we started working on the plan. We had noticed that there was a need for the seniors in the community. There were resources that were available, and we weren't being able to bring them to the patients in the hospital.
The program was brought to myself and to the Freeholder Board as the potential of a collaborative effort between the Newton Medical Center, a regional hospital, and the largest network of doctors, the Premier Health Group, as an innovative way to enhance the quality of life for our seniors, to track those that are discharged from the hospital, coordinate their care, and as a cooperative effort between those three entities.
So with advances in medicine and healthcare delivery, the way we think about how best to maintain health continues to evolve. We are looking at the practice of medicine from fresh perspectives, and clinical researchers and practitioners are finding out what systems and what strategies work best.
Often when a person transitions from the hospital to home, they don't have the support services at home to make that transition successful. And so often what happens is, because they are now in their home, they're alone, they don't have anyone caring for them, they readmit.
So older adults, especially those with multiple chronic medical conditions, are particularly vulnerable to this post-hospitalization state.
Initially, people would think that medical reasons would be the reasons that people would go back to the hospital, but we found that that is not necessarily always the case. So when we looked at the records at the hospital, we found that there were some things like being able to get transportation to their doctor's visits, keeping their first doctor's visit, prescriptions, and the ability just to be able to get the supplies that they needed were really issues. So they weren't really medical issues. They were more social services and human services issues.
And we were looking at different transitional care programs that were going on other places in the country, one of them being Mary Naylor's program at the University of Pennsylvania. I enrolled in that class and became a transitional care nurse. And we started working with the local physician groups and trying to figure out how we could establish our own program.
So we started to look at that in more detail and found that there was a real need for the program within Sussex County.
With the partnership of some physicians in the Premier Medical Group and investment by the county, we created our own transitional care team and started doing research with the patients in Newton Medical Center and then partnered with them to create this program.
I think the Transitional Care Program is an excellent program and a wonderful way of collaborating with Sussex County Department of Human Services and the hospital Newton Medical Center.
People will benefit from this program mostly because of it will help the quality of their life, and also it is very cost effective.
This program will be very beneficial to me. Regina is very informative and helpful in completing paperwork needed to be submitted for services offered to the seniors. She spent a lot of time with me and my daughter and is a very caring person.
Basically what we do is we identify patients once they've been admitted to the hospital. We do use a screening tool to show that they are high risk for readmission because of the complexity of their case.
It's important to recognize that the time immediately after hospitalization is a period of generalized risk for various adverse health events. Not only are the patients recovering from their original acute illness, but the physiologic stresses that they've experienced in the hospital also plays a toll on their already weakened state.
Once they're identified, they're assigned to a social worker in the transitional care team who does an assessment of needs. We do a community screening to find out what resources they need to keep them in the community and independent as long as possible.
We're able to go into the nursing facility and be able to work with their discharge planners. So after they meet us in the hospital, they're able to have that connection with us while they are getting rehabilitation in the nursing home.
So I received the discharge notification that Mrs. Kane is going to be discharged home soon, so I thought we might talk a little bit about the plan for her once she goes home.
Okay, that'd be great. The day that she discharges, our nurse will go over the discharge packet with her, and that'll include the meds that have been ordered, the services and the equipment for home.
Once the patient is discharged into the community, our team of social workers actually goes into their home.
Once they're identified, we start linking them with all the available resources and start working with their outpatient medical team, which could be home care, their primary care physician, as well as the hospital, to make sure that when they're discharged back home, all the resources that they need are in place.
We follow up on all the information that we were able to develop in the hospital, and we do a personal health record with every patient. We do that because we want to make sure that the patient knows the medication that they're taking, why they're taking it, and that there's not a conflict between the medications they were taking while they were in the hospital and once they get home.
Then I go to the hospital every day. I also get an update from the case management to update the doctors on how their patients are doing.
So with the transitional care program, we link them to services, whether if they need prescription drug coverage or just even to go get their prescription drugs for them, transportation, home health care, nursing services, so that they are in the home, they are getting that assistance and that support, which enable them to stay there and not have to be readmitted to the hospital. And they work hard to ensure that the patient's healthcare providers are kept in the loop about the patient's latest health status. The older adults, they have Medicare, 65 and older, they have Medicare, and it's very confusing. That is their health care, and they don't understand it. And what we can do is help them navigate through the Medicare system.
Had it not been for this group, I do not know when I would have taken up the reins of my life again. I now find confidence in returning to work.
The benefits really are, first and foremost, enhancing the quality of life of our senior citizens who were in the hospital for whatever reason.
Readmissions to hospitals, we found, is just not because of medical reasons. Readmissions to hospitals occur because people have difficulty navigating the system, figuring out their insurance, getting the little things that they need.
There have been multiple problems that have been associated with readmissions, and I think sometimes something as simple as making sure that when someone is discharged, all of the services that were ordered actually show up.
This program of care ensures a continuity of care across the patient's healthcare providers, lowers the risks of unnecessary and preventable admissions to the hospital.
And I just can't thank them enough and be grateful enough for them. Anything we asked of them, they would do, answer questions, or if you didn't understand something, they explained it to you. They couldn't have been more helpful.
So something as simple as was the hospital bed delivered? We had an opportunity. We had one situation where we did a home visit shortly after discharge and found an 89-year-old gentleman who was unable to move, laying on the floor of his house with pillows surrounding him because his elderly wife, who had also her own chronic disease, was unable to get him into the bed. And it was because the services were not there when they should have been.
Get them connected to transportation services. We make an appointment so that they visit the primary care physician within a very few days after they're discharged, so that there can be follow-up, so that if there's any changes in medication, in the course of treatment, we can help the patient navigate that whole system.
Last night we had a patient who we received a call at about 8:30 last night that she wasn't feeling, right. She's 95 years old and lives independently. We sent our LPN out, who did lung sounds and took her blood pressure, and saw that she was very sick. We immediately called 911. Were able to arrange the transport. Her med list was transferred with her, so there was an accurate relaying of information. So when she got there and would be normally unable to remember what medication she takes, what tests she's had, we have a personal health record that assisted her. So when she got there, the ER physicians knew what her story was because we placed a call beforehand, and her medical record was included with her bag. So she was there, and it made it a much smoother transition for her and the hospital staff.
I think one of the best parts is that you have someone calling you on a weekly basis to check in.
Meals on Wheels is a program that's provided by funding through the county. Sussex County has a vibrant Meals on Wheels program.
One of the programs that we work on, Take Control of Your Health, is a wonderful program. It's more like a workshop for individuals who have chronic conditions, or anybody who is a caregiver for individuals with a chronic condition. Those chronic conditions would be high blood pressure, diabetes, osteoporosis, lung diseases, and what they do is it helps enable the individual to take a more active role in their health and manage those conditions better.
It appears that we have all the right ingredients and all the right people to keep this successful program going.
And we have other services in the county that we need to coordinate with in order to make sure that whatever a patient needs, we're able to get them.
A great program which helped me get information I did not know about or ever knew I was eligible for.
And one of the things in Sussex County that we know that each admission to a hospital costs about $9,000 in the system.
Overarching all of this is really the need, as has been reported in the press widely over the last year, to reform the Medicare system and save costs, taxpayer costs, through reducing the cost of Medicare.
We also know that through the Division of Senior Services, we have a lot of seniors who call us or visit the office looking for programs that would help them. And unlike what was occurring a few years back, where your senior programs would be focusing on the illness part and knowing what medications to take, we're now focusing on the wellness part. And that really contributes to keeping an individual from being readmitted to the hospital.
I can't stress enough the importance of the program as a relationship between the community and the hospital. The hospital's mission is to improve the health of the community, and one way of doing that is through this partnership with the county, making sure that the patients that come into the hospital that are admitted transition home safely, that they have what they need at home.
It's just a very kind way of treating our seniors and also saving at the same time a great deal of money. So I think the Freeholder Board is very supportive of this.
It puts a presence of a social worker from the program right in the hospital, and then it's easier for case management and social work to be able to refer directly to us.
We have the goal of reducing readmissions by 20%. How are we going to do that? We do that through the program that we've implemented, but we also have a lot of discussions with agencies that are not only state representatives but federal representatives. We've talked to subcontractors for the Center for Medicaid and Medicare Services, commonly referred to as CMS. They're the regulatory body who actually are working on the implementation of the Affordable Health Care Act.
Patient confidentiality is an important area that all healthcare providers are concerned about and pay close attention to. And in the same way, all of the healthcare providers in the Transitional Care Program adhere strictly to HIPAA rules or patient confidentiality rules. And that all of the patient records that are accessed are strictly being used by the providers in the Transitional Care Program solely for the purpose of coordinating care across these healthcare settings.
We've been really successful at the readmission rates, and the last data that we received from CMS, that New Jersey and Sussex County had about a 17% readmission rate. The transitional care team is below 10% or close to 9% for readmissions. So it's working, and that's really a good feeling because we've always known that there's a place for social services in the healthcare model, and now we're starting to collect data to prove that.
Keep in mind, these are elderly patients, and a lot of times once you come out of the hospital, you're still confused and you don't have that support mechanism that's readily here. Your kids have moved away. You may live in a remote area. So we help them prepare for that, and we help them navigate that, and that's why our case managers are constantly on the phone with them, checking up with them, making sure that everything is going well.
The Transitional Care Program is free. There's been an investment by Newton Medical Center and the Freeholder Board to continue to further the programs that are currently available. So things like trying to supplement services that perhaps people couldn't afford on their own. We now have some resources available financially to try to help patients. But at the very minimum, the basic transitional care services are available to any residents who are over 65.
It improves the patient outcomes overall, meaning that the patients have a better quality of care when they actually have a collaborative relationship between the community and with the hospital.
I think when you go home from the hospital, the last thing you want to do is go back in the hospital. So you might not be feeling well, you might be having symptoms that return, and you don't want to tell anyone because you think you'll end up going back in. But most of those things can be taken care of at home.
I feel very fortunate to be part of an innovative program that we're able to work together as a team and be able to provide services to seniors that they may know about in the community but might have trouble linking to.
It's a great way to promote health in the community, and the more people we have involved in this program, the better it will be for the patients and for the community overall.